Lieutenant Colonel Dr. Nate and I'm one of the sports faculty here at Fort Belvoir, and I'm going to speak to you on compartment pressure measurement. We're going to get right down to it. So, first of all, the indications for measuring the compartment pressure would be suspected acute compartment syndrome, which often follows a crush injury or acute trauma, oftentimes a fracture, or a chronic exertional compartment syndrome. So we'll talk a lot more about that. I'm not going to get into the weeds there, but when you're suspecting acute compartment syndrome, we're looking for the 5 P's, which is pain, paresthesias, pallor, pulsionosis, and poikilothermia, or a cool extremity. And really, pain is what takes the cake there. So the device itself looks like this. The picture on the left is a needle manometer. It is got a needle that's got a side port as well as an opening on the end of the needle, and we'll see those in clinic. We'll do one of these together, but this is the device that we use most typically, is the one on the left. On the right, there's 2 smaller images which you can basically just look at and probably forget because you'll never see them probably. The one on the bottom right is a transducer tipped catheter. Those can be used for continuous compartment pressure readings, but those are mostly only used for research or in Europe. So next slide. As far as setting up for the procedure itself, you're going to need the pressure monitor itself. You're going to need prep, sterile gloves, gauze bandages, etc., stopwatch, pretty typical stuff. You do need a treadmill or a way to exercise the patient to reproduce their symptoms. And most of us do this with at least some level of ultrasound guidance, and we'll talk a little bit more about that. First of all, the anatomy of the leg. There are obviously 2 bones, the tibia and fibula. Between them, there's an interosseous membrane, and there are neurovascular bundles that run both anterior and posterior to that. There are 4 compartments. The anterior compartment here is in yellow. The lateral compartment is in green. The deep posterior compartment is in red, and the superficial posterior in blue. So each of those compartments contains multiple muscles and neurovascular structures and is bounded by a dense fascia. For the procedure itself, you're going to need to mark the sites for needle insertion. Some of this should be done with ultrasound. The anterior compartment and arguably the lateral can be done without ultrasound guidance if you know the surface anatomy well. But you know, there is certainly judgment call there. Getting into the deep posterior compartment probably needs ultrasound to be done reliably. And some people do ultrasound guidance for all of them. You'll want to obviously clean the skin. The 3 main steps that I think are easy to mix up are I've bolded. You're going to need to get the device at the angle for insertion, which is going to be perpendicular. You're going to zero the device. You're going to insert it into the compartment and get the tip of the needle well within the compartment. So for somebody who's obese, you're going to have a lot of sub-Q to go through. You're really going to feel for a second pop as you go through that fascia of the muscle. So once you've got the needle tip confidently within the muscle compartment, you're going to inject about ½ milliliter of saline, or maybe just a little bit less. Just need a light little tap on the plunger. The purpose for that is to clear any tissue plugs. Like sometimes you'll actually do a little mini muscle biopsy and get a core of muscle tissue actually stuck within the needle. So you have to push that little thing out so that you have a column of fluid directly through the needle all the way into the part of the device that senses pressure. Once you get it in there, bolus it, then you're going to see the pressure values peak, and then they're quickly going to tail off, and you should see a little plateau in the reading, and that's the level that you want to record. And once you get that number, you can simply withdraw the needle and move on to your next site. Once you have measured the pressure at each compartment on each leg that is clinically indicated, Then you're going to dress the sites, usually put gauze and some Coban around it, and then put the patient on the treadmill. And you're going to put them on the treadmill until they reproduce their symptoms. And again, this is for chronic exertional compartment syndrome. If you were suspecting acute compartment syndrome, you're simply just going to measure the pressure itself and not exercise them, obviously. Once they really get very symptomatic on the treadmill for a chronic exertional patient, you're going to have them run basically till they can't go anymore, and then pull them off, put them back on the exam table, and repeat those pressure measurements. Traditionally, that's done at 1 minute and 5 minutes post-exercise. This is the Pedowitz criteria. I'm going to talk to you more about the Pedowitz criteria here in a minute, but about I guess the downside of this criteria. But this is what is still on the boards as far as I'm aware. Before exercise, any compartment pressure of 15 millimeters of mercury resting is considered positive. 1 minute post-exercise, over 30 millimeters of mercury is considered positive, or 5 minutes post, over 20 millimeters of mercury. So that is worth memorizing because, again, it is board fodder, and you may get asked this. So 15, 30, and 20 is the numbers you need to remember. But I want to tell you about this because there's some problems with the Pedowitz criteria. There are many confounding factors with intramuscular compartment pressure testing. There are negligible correlation between pain and pressure. You can see the graph on the upper right, which was from a study by Zimmerman. We'll talk to you more about this throughout the year, but pain and pressures, compartment pressures, have a negligible to no correlation. We also know from the Pedowitz study in 1990 that it was very poorly done. It was invalid. The way they analyzed the data, the way they divided the patients into groups was invalid. So it's that there's been multiple studies, multiple authors who've called that out in the last 10 years, and it's well known that the study was poorly done. However, it still kind of hangs on in practice. We also have studies showing that intramuscular compartment pressure does not predict the outcome of fasciotomy or other treatments. So the bottom line is we really don't understand the pathophysiology of chronic exertional compartment syndrome, and we do not have a valid diagnostic reference standard test. So without getting too much into the weeds on that, I want to tell you a little bit about the confounding factors with the muscular compartment pressure testing itself. Leg and ankle position during the testing might vary. People do it differently. I've shown in these photos how I do it. I like to have the knee bent and the foot resting flat on the table because I don't want the weight of the leg compressing the muscles against the table. I think that can affect the reading that you're getting. People do use different exercise protocols. It is very hard to get on-time measurements within all of the compartments at 1 minute and at 5 minutes. It just really can't be done. So the timing of those measurements might vary. The type of the device varies. The depth and angle of needle insertion might vary. And when somebody's obese, it makes it even harder. Do you use ultrasound guidance or not? Do you just mark the sites with ultrasound guidance, or do you actually directly visualize the needle entering the muscular compartment while you're doing it? Furthermore, does it matter which muscle within the compartment you're in? And it just goes on and on. Do you use lidocaine? Do you not use lidocaine? Does the volume of lidocaine matter? Does that extra fluid in the tissues affect the compartment pressure? So there's just many things that might lead to variable outcomes and maybe poor reliability with that test. But it's important to know this test because a lot of surgeons still require it if they're going to do a fasciotomy. What do we do? What is a primary care sports medicine physician supposed to do with this information today? Well, history and physical exam is very important. You need to take a thorough and high quality history exam. So if you suspect chronic exertional compartment syndrome, get x-rays. Do gait retraining. We can talk more about that throughout the year. If they're failing this non-invasive treatment, consider getting an MRI and revisit things that are non-surgical, things like gait retraining. Have they been losing weight if they need to lose weight? Have they considered Botox? Have you talked to them about that option? And again, I know this is not something we've taught you yet, but we'll get into it later in the year. And finally, if they're still not improving with non-operative treatment, that's where I would recommend getting intramuscular compartment pressure testing, and the criteria that many experts in the field today use is a 1 minute post or a 5 minute post exercise threshold of over 35 millimeters of mercury in any of the compartments would be considered diagnostic for chronic exertional compartment syndrome. So once you've made the diagnosis, then again, treatment algorithms, there's non-invasive, there's minimally invasive, and then there's the fasciotomy, but we'll talk about those things throughout the year. So hopefully this has been helpful to you. This is a procedure that you should know. We will do, depending on what setting you're in the military, we use it not infrequently. Thank you very much for your attention, and we'll answer any questions when we get the chance in person. Thanks.